right, so we will let people join in. Usually within the first 10 minutes, people pop on, but I will get started. So Dr. Heapy is out today, so I'm going to take over hosting and announcement duties. So next month, June 1st, we'll have Dr. Elizabeth Goldsmith is going to present from the VA Evidence Synthesis Program Report. So it's implementation of psychotherapies and mindfulness-based stress reduction for chronic pain and chronic mental health conditions. And this was requested by the HSR&D Pain Opioid Consortium for Research, or the CORE. She'll present on that on June 1st, and I'll send out reminders for that. After June 1st, we'll take a summer break, as all of us likely need it. And there won't be any presentations in July or August, and we'll likely start back up in September, potentially on a different platform with the ever-changing platform preferences and what people are able to find most useful in presenting. So we are really happy to have Dr. Qeadan and Dr. Madden here today. Dr. Qeadan is Associate Professor of Biostatistics and Public Health Sciences Department at Loyola University Chicago. His interests include data science and health informatics, surveys and sampling, population health and big data, and geographic information systems, GIS, and statistics for health, ecology, and climate. Dr. Madden is an assistant professor in the Department of Family Medicine and Public Health Sciences at Wayne State University School of Medicine. She's a medical sociologist who studies prejudice and discrimination towards people who use drugs, and especially stigma related to harm reduction interventions and medication treatment for opiate use disorders. We're really pleased to have both of you here. I will turn the floor over to you. I'm looking forward to your presentation.
Thanks so much for having us. So I'm going to start us off. We're going to talk to you today about some research we've been doing related to naloxone prescribing to acute and chronic pain patients using medical records data. So we have no conflicts of interest to disclose, but we would like to thank the University of New Mexico, who provided the funding and data support for this project. Both Ferris and I used to be faculty members at the University of New Mexico School of Medicine, which is where we got the data, which we'll talk about the data later when we get to the methods. So I'll start us off by talking about some background, specifically talking about naloxone prescribing and then drug overdose, drug poisoning among pain patients. Ferris will talk about the research methods and results, and then I'll come back in to bring up some points for discussion and provide our conclusions. So most of what we're talking about today is research that was published in Addiction in 2022, a paper titled Associations Between Naloxone Prescribing and Opioid Overdose Among Patients with Acute and Chronic Pain. But we're also going to touch on some other research we've done in this area and talk more broadly about naloxone prescribing for pain patients as well. So to provide some background that I'm sure you all are familiar with, U.S. overdose death rates have obviously been climbing, especially between 2019 and 2020. A lot of this is, of course, driven by opioid overdose in particular. So provisional counts from the CDC for more recent periods show that it's synthetic opioids, specifically likely illicitly manufactured fentanyl, that are really driving drug overdose deaths in the United States. So the black line is all opioid overdose deaths over time, and then the brownish line is synthetic opioids like illicitly manufactured fentanyl, which have obviously increased dramatically since 2016. And you see, heroin is relatively flat compared to synthetic opioids in this period, methadone relatively flat, and a declining trend for heroin, and a sort of flattish trend for natural and synthetic opioids, which are often prescription opioids. So naloxone, of course, is a tertiary response to the problem of opioid overdose death. All of you probably know what naloxone is, an opioid antagonist that temporarily reverses sedation and respiratory depression that occur during an overdose. Of course, naloxone's been around for a long time. It's been traditionally, though, the realm of harm reduction programs that distributed this not on a prescription basis. So syringe exchanges, which should be really called syringe distribution programs, were the ones who were giving out naloxone in communities. However, there's been an increase in co-prescription of naloxone with opioids in clinical contexts. So what is driving the increase in the clinical use of naloxone prescribing? Well, there's some policy drivers that have been part of what's going on here. So recommendations from some organizations and agencies. So for example, in 2014, Indian Health Service added naloxone to its national core formulary and recommended its prescribing along with opioids for pain. And I'm sure you're very familiar with the 2016 CDC guideline for opioid prescribing for chronic pain mentions naloxone as a tertiary intervention for chronic pain patients who might be at risk of overdose. And then, of course, states have become involved in encouraging naloxone prescribing. So at least 17 states have passed laws supporting naloxone prescription for patients at risk of overdose. These started in 2016. And unlike the CDC and Indian Health Service guidelines, some of these are actually legally binding, though some state laws are still a recommendation. So there's policy drivers here. And in terms of the state legislation, PRWG and colleagues have done a good job of characterizing these for 2019 and earlier. This is their map that shows the dark blue states are the ones that are mandating a sort of legally binding form of prescribing recommendation. The middle blue is California and Ohio are mandating at least an offer of prescribing. The light blue states are recommending prescribing through legislation. Most naloxone prescribing laws apply to all prescribing health professionals, though some do specifically apply to prescribers of controlled substances. That'll be Florida and Utah's laws, or prescribers of opioid analgesics, which is New Mexico's law, or sometimes to specific types of clinicians, which are Ohio, Virginia, and Washington laws. And then clinicians in select practice settings are sometimes targeted by laws like New Mexico's. So which patients are targeted by these naloxone policies? Well, the most common sort of patient population that's named in state policies are those receiving opioids over a particular morphine milligram equivalent, though what is that threshold varies by state. So 10 states recommend this, but they have different thresholds. They don't all use the same one. Also, 9 states say people who are getting both an opioid and a benzodiazepine prescription should be prescribed naloxone. Other laws talk about clinical history. For example, 7 laws talk about if a patient has a history of overdose, they should be prescribed naloxone. Only 2 actually name chronic pain patients as the targeted patient population. Other guidelines like the 2016 CDC opioid prescribing guidelines for chronic pain say chronic pain patients who have some of these other traits, right? Chronic pain patients who receive opioids greater than or equal to 50 morphine milligram equivalents a day, have a history of substance use disorder, overdose, have concurrent benzodiazepine use. Those are the ones that should be getting naloxone prescribed to them along with opioids. So me and Dr. Qeadan's question is, how are clinicians actually prescribing naloxone? So we know that there's these policy drivers of naloxone prescribing. And of course, doctors read the news, right? People are concerned about rising rates of overdose. But we wanted to know in our research, what are prescribers actually doing? So we had thought about, there's these studies that show that there's racial and ethnic inequities in who gets opioids. And of course, there's been a lot of evidence that, this occurs for both chronic pain and acute pain, mostly finding differences between non-Hispanic white populations and Black or African-American populations, though some evidence of also inequities related to Hispanic populations as well. So we wanted to know, are there also racial and ethnic inequities related to naloxone prescribing among the people who are getting opioids? And we found in a 2020 paper that's published in the journal Substance Abuse that yes, there are racial and ethnic inequities in naloxone co-prescribing as well. So we did a cross-sectional study of patients. We used two examples of pain, long bone and shoulder fracture, which is used in studies of opioid inequities by race, and then chronic pain syndrome, which is an example of a prognosis with a less defined duration, which was suggested in other studies of racial and ethnic differences in opioid prescribing. And then CPS, chronic pain syndrome, was actually one of the most common conditions in our database for which opioids were prescribed. So we chose those 2 as examples. And what we found was that Black and African-American patients and patients with other race or ethnicity listed in their medical chart were less likely to receive naloxone than non-Hispanic white patients. And then we found with chronic pain a different type of trend. We found Native American and Hispanic patients were more likely, to receive naloxone than non-Hispanic white patients. And in terms of the magnitude of these differences, for fracture, Black or African American patients were 30% less likely to receive that naloxone prescription. Patients of other race or ethnicity were 17% less likely to receive a naloxone prescription. And then for Native Americans, they were 49% more likely to receive a naloxone prescription, and Hispanic patients 62% more likely. This is a cross-sectional study. We can't tell you why this was happening, though we have some ideas that we talk about in the paper. For example, Native American patients maybe are more likely to get naloxone because of that Indian Health Service policy that was recommending use. But there's also some other reasons that might be going on related to prescriber conscious or unconscious bias, assumptions of who is likely to overdose or not listen to what they should be doing, or who uses drugs could also be at play here. So we became more and more interested in this idea of who is prescribing naloxone, how are they doing it, what's going on with clinical naloxone prescriptions. So we became interested in thinking more about this idea of chronic pain and overdose. And what we found, of course, reading the literature, is that there's really mixed evidence that chronic pain patients face a higher overdose risk, and maybe, the evidence is leaning more towards they don't face a higher risk. And the results, of course, might be tainted by opioid prescribing, as noted in Agnoli and colleagues' JAMA paper, and then Dr. Oliva, who is here, the paper on VA opioid tapering, that this could also be a piece of the story for why chronic pain patients face any opioid overdose risk. Though thinking about a different denominator, when we're talking about all the people with opioid use disorder, chronic pain is more prevalent than the general population. People with opioid use disorders, some estimates say about 75% may face chronic pain issues compared to 30% in the general population. And what we sort of notice is that there's not much that's known about subsequent outcomes among acute or chronic pain patients that are co-prescribed opioids and naloxone in clinical contexts. So our research question is getting at this sort of gap in the knowledge. Has naloxone prescribing in clinical contexts targeted those pain patients who are most at risk of overdose? So I'll hand it over to Ferris to talk about how we went about answering this question.
Thanks, Erin. Thanks, Erin. Can you move the slides forward? Thank you. All right, so the data source that we use for this project is coming from a national database. Is called Health Facts, the Cerner database. It's currently has a different name. It's called Real World Database, Cerner Real World Database. At the time when we conducted the study, the size of the database was roughly 60 million unique patients coming from about 600 hospitals and clinics. In recent year, the size of this database became almost 100 million unique patients. So you can imagine why we are using, how we are able to answer such questions with rare events like this, because we have available a massive database to look at. Now, to identify the diagnosis for bone fracture, chronic pain syndrome, CBS, and low back pain, we use the ICD-9 codes and ICD-10 codes. Of course, the ICD-9 codes for the time period up to October 2015. But after October 2015, to be more specific, we start using the ICD-10. Now, to identify opioid prescriptions and naloxone prescription, maybe we didn't mention here the opioid, but the same, both of them, we use NDC codes. I think for naloxone, we have almost 49 NDC codes, but for the opioid prescription, we have almost 3,000 of NDC codes for opioid prescription. Now, our cohort entails 3 different health conditions: CBS, fracture, and back pain. But as you know, patients could have all of these conditions at the same time. They could have at least 2 of them, or could have just 1 of them. And this Venn diagram illustrates the sample size for each health pain condition. So as you can see here, the largest one is the low back pain, where we have almost 792,000 patients. And the smallest one is the CBS, chronic pain syndrome, which is 76,000. And in between is the fracture patients. Now, just to clarify, In this Venn diagram, you can see, for example, we have 2.10% of our cohort are patients who have both back pain and fracture. Now, in the analysis, we did a sensitivity analysis where we stratified our analysis by health condition, by CBS, fracture, and back pain only, and whether they have other health conditions. So, and we get results that are very similar to each other. So, why we are talking about this, just to show that the results were robust. Even if we explicitly just for CBS patients did analysis, or fracture only did the analysis, or back pain only did the analysis, we obtained roughly similar results as if we included fracture patients that also have CBS and also they have back pain. So this is just a note about our analysis. We are presenting only one, but we did both as a sensitivity analysis just to show the robustness of our study. All right, so this study pretty much is a retrospective cohort study design. We followed patients for 2 years, and in our baseline, so we defined the exposed group and the non-exposed group. And in here, we've been very strict. Our exposed patients are those who were diagnosed and with the health condition, either it's a fracture or CBS or low back pain. And at the same encounter, they were prescribed opioids and naloxone. So this is our exposure group. The unexposed group, also patients who were diagnosed with those health conditions, and at the same encounter, they were prescribed opioids, but however, they were not prescribed naloxone. And by design, if we run analysis for any specific outcome related to naloxone, this will illustrate and show the association or the influence of naloxone prescriptions on this particular outcome you are studying. And this is how people design studies. Okay. Now, in our analysis, we use the SAS for our analysis. And the results were obtained by using separate models for each diagnosis group. As I mentioned, we did stratified analysis. So we have, for each health condition, we have 2 models. Like, for example, for CBS, we have one Cox proportional hazard model and one quasi-Poisson regression model. Let me illustrate the difference between the two, which is, most of you maybe are more likely familiar with the difference between the Cox proportional hazard model and the quasi-Poisson regression. So in the Cox proportional hazard model, we have naloxone prescription as our primary exposure, and the outcome is time to the first subsequent opioid overdose. Now, in the quasi-Poisson regression, because we have subjects who have more than one opioid overdose, we could account for that in the analysis by looking at the number of subsequent opioid overdoses. So since we have the count of opioid overdoses as the outcome, we have to use a Poisson regression. And however, due to violation of equality of mean and variance assumption, which is the fundamental assumption for Poisson regression, we chose quasi-Poisson regression as opposed to negative binomial, while noting that both models actually gave similar results. So we are good there too. Erin, okay. Now, in these models, both models, we have adjusted for MME. We also adjusted for benzo prescriptions, OUD, opioid use disorder, and also other substance use disorders, but non-tobacco ones, and history of overdose, giving that we know that history of opioid overdose may be the most impactful on subsequent opioid overdose. So we have to account for such confounding variables, and this is why we are listing such covariates in our model. Of course, history of mental health, mental illness, COPD, or sleep apnea in the literature found to be associated as well. So we have to adjust for them. We did adjust for some demographics that are available in electronic medical records. As you know, when you deal with EHR or AMR, Sometimes you don't have the luxury of choice what variables you want to adjust for in terms of sociodemographic ones, because you get what you have there and there is nothing you could do. In our database, we were lucky to have biological sex, age, race, ethnicity, marital status. Marital status is always useful because sometimes it's a proxy for social support. And we also have insurance type we adjusted for. And we have some characteristics for hospitals and clinics, whether the hospital and the clinic is located in a rural or urban area. Also geographically, we have to the level of the census division. So we have 9 census division, which gives you regional variability to capture. And it's not listed here, but also we use hospital ID as a cluster in our models by using GEE. And the reason for that to account for variability in healthcare settings between hospitals. And given that we have data from 2009, 2017, and prescriptions behavior change over time, we also adjusted for the year. And so there's motivation for why we are including each one of those covariates, but we could explain more, but this is in a simple way why we included those variables. Now, in our results, as you can see here, it seems like what we found for fracture and CBS, that prescription among those with long bone fracture and those with chronic pain syndrome, 23% were prescribed naloxone at the encounter when they were prescribed opioid at the encounter when they were diagnosed with those health conditions. Okay? It seems like with the fracture and CBS, we have roughly 24, 23, 25, 26%. But if you go to low back pain, it's only 14%, 13.95% of those who were diagnosed with low back pain. At the same time, they were giving prescribed opioid, and only 14% of them were prescribed also naloxone. So we have here some variability. Now, if you look at the outcome, the primary outcome of our study is opioid overdose. And as we mentioned, we adapted 2 techniques, the Cox proportional hazard model, which is the time from naloxone prescription until the subsequent opioid overdose. And also we did the quasi-Poisson regression model, where the outcome is the number of subsequent opioid overdoses. And in this table, for each health condition, a pain type, whether it's fracture or CPS or low back pain, we tabulated the distribution of the number of the frequency of opioid overdoses. And as you can see, it's almost always a very small percentage. This is a rare event to have an opioid overdose. That's not something that happens for the majority of the population, right? And as you can see in the last row, for fracture patients, only 0.16%, 400 subjects encountered experienced opioid overdose. Now, of course, some of them we have only one, like we have only 2, half of them have only a single opioid overdose, but the other half, they had either twice or 3 times or 4 times, even 6 times or more. But again, this number is declining as you go with the number of opioid overdoses. But if you look at CBS patient, which is not surprising, this is chronic pain syndrome, you can see the number is totally different. It's like 1.28%, way higher than 1.16%. And we have the distribution of the number of the frequency of opioid overdoses, where we have once or twice or more. The same thing with low back pain. Erin, you want to go to the next one? Now, this is the main finding of this study, using the Cox proportional hazard model to model the time from naloxone prescriptions up to opioid overdose. All right. And while we are interested in the first row of this table, the other results are also relevant to us to know about, but we will focus in the first row because that's the main finding. And what we are finding for bone fracture patients, we have 87% higher has a higher risk of experiencing opioid overdose among bone fracture patients who were prescribed opioids and prescribed naloxone versus those who were diagnosed with bone fracture and prescribed opioids but not prescribed naloxone. So this shows you the association or the impact and the influence of naloxone prescriptions in this outcome of interest that we have, which is opioid overdose. Similarly, if you go to CPS patients, we get similar hazard ratio, 1.69, and you can look at the confidence intervals. They don't overlap with one, so we have significant results, while noting we are adjusting for an array of relevant variables that associate with the outcome. So this is kind of a pure association because we are removing the effect of opioid MME. We are removing the effect of benzo and history of mental health and history of OUD, of overdose, all demographics, right? So we see that in bone fracture, for CPS, for low back pain, we have higher risk for experiencing opioid overdose, for those who were prescribed naloxone versus those who were not prescribed naloxone. And there is variability, though, where you can see for bone fracture, the confidence interval does not overlap with the low back model, right? So 1.87 significantly higher than 1.33. So we should keep that in mind. There is some variability, while in the three pain ties, we have higher risk, okay? All right, it's good to mention, go back, Erin, please, if you mind. So if you go to the previous one, this one, you can see like overdose history, we were expecting this finding. Like we know this is one of the most contributing independent variables to opioid overdose, and we can see that in our model, which is reassuring. What we were expecting, we are seeing in here. But it was good. We thought it's good to highlight this in here to show that we are adjusting for important variables that contribute to the outcome, so that the effect we are capturing for naloxone is pure, is not confounded in any way. Okay. We obtained similar results while looking at the quasi-Poisson regression models. Again, the outcome in here is no longer time to subsequent opioid overdose. It is actually the number of opioid overdoses. So some patients have 0 opioid overdoses. Some people have 1, 2, 3, 4, and so forth. So we have the count. And here the effect size is not hazard ratios. The effect size here is the incident rate ratio, IRR, which is pretty much a proxy for risk, similar to hazard ratios, a proxy for risk. Also, logistic regression, which is also we have done, but we are not maybe reporting here, also is a proxy for risk. So we looked at the hazard ratio, the odds ratio, the incident rate ratio, and the three of them were consistent. They were close to each other, and they give the same story. Okay, and in here, what the interpretation would be, for example, for bone fracture, is that naloxone prescriptions is associated with 89% higher risk for opioid for incidence, 89% higher incidence of opioid overdose compared to those who were not prescribed naloxone. Okay, and again, those other covariates we adjusted for, they show a similar effect size. Okay, Erin. Now, in summary, how we could summarize these results across types of pain. Naloxone prescriptions in the clinical context are significantly associated, number one, with increased risk from 33% to 87%, depends on the type of pain, for subsequent overdose. This information was gleaned from the Cox models. And also we learned that naloxone prescriptions in the clinical context are significantly associated with a greater incidence from 35% to 89%, depends on the type of the pain, of subsequent overdoses. And that was gleaned from the quasi-Poisson models. And all of this was done among patients prescribed opioid, even after controlling for relevant covariates. Okay. All right, I'm going to hand it back to Erin. She could highlight some discussion points and some conclusions about the study.
Thanks, Faris. So the overall story here is that we got a good answer to our question, which is that prescribers, what are they doing? They're correctly identifying individuals who are most at risk for opioid overdose, opioid poisoning among chronic pain and acute pain patients, and then they're prescribing them naloxone. So to me, these are really promising results that tell a good story of what's going on with clinical naloxone prescription. We also see, the expected results for the covariates for overdose history, opioid use disorder history, substance use disorder, and naloxone remained significant as a predictor of subsequent opioid overdose. So why? Well, this is a cross-sectional study. We don't actually totally know the reasons for why, but we suggest a few in our paper and have talked about a few. We think that maybe it's that prescribers are soliciting additional information that's perhaps not captured in electronic health records about overdose risk factors. So things like homelessness, physical signs of injection drug use, and maybe others that we haven't considered, that you all maybe have considered or have some ideas, that maybe that's influencing how prescribers are making decisions about who gets naloxone. But what this is telling us is they are identifying people who subsequently are at risk of overdose, and they're getting naloxone to those individuals, which is all good news. Though, of course, some people might look at this study and say, is this a study that's supporting risk compensation? So maybe some of you are familiar with this idea. What risk compensation is, for those of you who are less familiar, is that this is an idea that when there's safety policies around, they might actually unintentionally encourage an increase in unsafe behavior because they're reducing people's perceptions of risk. So this would be like potentially people could act in such risky ways in response to a safety intervention that they would actually nullify the effects of the safety intervention, right? So this is the idea that, if you give people naloxone, they're just going to use drugs in riskier ways, and that's actually going to increase the rates of overdose. I'm sure all of you have heard this objection to naloxone, and it's very common. Of course, there's also no meaningful evidence that this happens in the case of naloxone. There's multiple studies showing actually the reverse is true, that naloxone does not encourage unsafe drug use and actually can encourage people to use in safer ways. However, risk compensation fears are real. They are, in my research, quite common. They're one of the sort of expressions of stigma, and also a driver of stigma sort of at the same time. This idea exists among the lay public. It exists among physicians. It also exists among law enforcement. So this is an idea that's out there. And our study does not measure risk compensation. We are not saying that because someone was prescribed naloxone, that is why they subsequently overdosed. Our results should not be interpreted as supporting that fear at all. And that's because our study design really doesn't allow us to speak to that question anyway. We don't directly measure risky drug use. I guess overdose could be sort of a proxy for risky drug use, but it's not a direct measure. And most importantly, we cannot measure the role of fentanyl and illicit drug markets that is likely the driver of the increases in opioid overdose that we are seeing. We are not blaming prescriptions for the opioid overdoses that we have measured here. We can't know that from our data either. So unless we were able to control for that really important factor, those important factors, and really measure what people are doing in response to naloxone, right, we can't speak to risk compensation. So this study should not be interpreted as supporting the idea that giving people naloxone actually makes them do riskier things and makes them overdose. We are not saying that at all with this study. So I want to say some more about the limitations of our data. So electronic health records are a great resource, especially for rare events, as Ferris described. However, they do have weaknesses. So we actually don't know whether naloxone prescriptions were filled using EHR data. We know that they were ordered by a prescriber, but we don't know that the patient actually got the naloxone prescription. You would need claims data for that. The reason why we actually continued using EHR data to answer this question, despite the fact that we don't know whether someone got the naloxone prescription, is that claims data only captures the insured population, really, and that we're actually able to better capture prescriber behavior, even to uninsured people with EHR data. So there's still some benefits here. We also don't know about people's access to non-prescribed naloxone through things like harm reduction programs that aren't using prescribed naloxone, they're just distributing naloxone. We also don't know about overdoses that occur outside of healthcare settings. We only know about those that come to a clinic or hospital using the Cerner EHR. We don't know whether an overdose is fatal or non-fatal. That's a weakness of the database. And then we don't know the details of patient education that maybe happened in the clinical encounter. We don't know if the person was given a lot of education about how to prevent an overdose or not. We just have no details on that from EHR data. So naloxone, of course, is just one of a variety of evidence-based harm reduction interventions that could be used to further support pain patients who are at risk of drug-related outcomes. That said, right, we're not saying that chronic pain patients are especially at risk of overdose. You saw in our data that overdose is a relatively rare event. However, there are some people, right, who are at increased risk of overdose. And what we think that these data kind of say is that we could build upon successful naloxone prescribing. We've shown here that there's some good stuff happening in clinical context when we're trying to integrate harm reduction interventions like naloxone, that we see that prescribers are using them and they're using them appropriately. So of course, this suggests that maybe there's more that could be done to build on that success. We could, maybe partnering with community-based harm reduction programs to further support acute and chronic pain patients who are at risk of adverse outcomes. And then, of course, this suggests some future research that could be interesting, examining patient-provider interactions to identify some of those unmeasured factors that are contributing to this appropriate naloxone prescribing that we've observed. And that's something that Ferris and I are working on, is considering the role of opioid tapering in naloxone prescribing behavior, that has not really been well established. So that's what Ferris and my next project is working on. So we just want to acknowledge the three people who really helped deeply with this study: Harry Snow, who helped us obtain our health facts data, and then Ferris's students, Jeanette Varela and Jesus Vasquez, who helped with all the ICD work. And we'll end it there and open it up for discussion and questions. Thank you so much.
Thank you very much, Erin and Ferris. If there are any questions, I can open for that. There was one question in the chat that came up when you were describing the population, asking if there was a washout period receiving opioids or naloxone.
Can you say it again? If there was a what?
If there's a washout period for receiving opioids or naloxone, I think is when you were describing the sample.
Yeah, so I could answer one. So what we did, we started the follow-up of the 2 years, 24 hours after the naloxone prescription. And the choice of the 2 years, that's the shelf life for naloxone is 2 years. But I'm not sure what meant washout period for receiving opioid and naloxone, when by construction we needed to have the opioid prescription at the same encounter of the diagnosis. So I'm not sure if somebody want to clarify what is the washout, unless they meant by it is after the naloxone prescription, when it was with the follow-up, when it was measured.
Yeah, so asking if they were new naloxone patients or naloxone users. I think was it Mark? If you can unmute too, if you want to clarify directly. I don't know if you have the capacity to unmute.
Yeah, can you hear me? Okay.
Yep, we can hear you.
Great. I'm just curious, because it appears that the index date you have, and then post-index date 2 years, you look to see whether or not these events occurred. My question was really about, because I didn't see it in your covariates, but like a history of naloxone use, like how long they've been on an opioid, for example. Like it occurs to me that those could be biased towards one or the other in terms of the outcome. So a patient who doesn't have naloxone at that index date may have had naloxone previously, and you said the expiration date of naloxone can be much longer than what the prescription life is. So what if they got naloxone, like say, a couple of months ago, but for some reason the index date you're using, they weren't prescribed naloxone for that encounter, and they were categorized as unexposed? Like, how would you handle something like that?
Yeah. So if for the exposed, they have to have the three in the same encounter. That's just to have to be able to have proper design to separate, to tease out those with naloxone prescription versus those who are not. Now, the issue is whether we accounted for, how is this the first time are they on naloxone or not? That's the question, right? Like for
right. Yeah, seeing they're like naive patients to this.
Yeah, we have done that only for history for opioid overdose and and everybody in the target population, both the exposed and non-exposed, have to be prescribed opioid. We haven't looked into this. We didn't account or adjust a control, whether it's a new or like, you know, have history of naloxone.
So I wonder if that speaks
thank
to
you.
something that. Oh, sorry, Mark. Go ahead.
Yeah, well, thank you for that comment. Yeah, I just feel like, I mean, patients who were categorized as unexposed versus exposed have understanding. I would imagine understanding the history of naloxone use would also predispose their risk for having an opioid overdose. It just seems to me that's something that would be an unmeasured confounder in this.
Yeah. So there is a lot of issues with the medication that we had to deal with, and remove a lot of like many record like patients from the target population because of like quality of the medication, the reporting, like in the electronic medical record. I can't recall exactly the specific examples, but there's a bunch that were removed because of issues like this. But I think this will. So if I think about it, I'm not sure if this will shrink the effects of the null or not. If we adjusted for a history of naloxone, maybe actually more likely will. Yeah, we have to investigate. But this is a good point, and to adjust for such effect that might play a role in the estimates. But I would highly be surprised if it will change an effective hazard ratio of 1.87 or something like this. It would be good to adjust for it, but I'm not expecting it to change the results of the study.
So so it's something that leads to a thought I was having in terms of, you know, if everyone was prescribed naloxone, then we expect that naloxone prescription would obviously have nothing to do with overdose. And if someone had been prescribed, and this might lead to Julie's question too, someone been prescribed naloxone at some point prior, and then part of that conversation with the provider was like, hey, do you have a naloxone prescription? And they said, oh yeah, I got one, you know, a couple months ago or something. Then they might not be written a script in that encounter. And they would be categorized as kind of a not prescribed based on the parameters of your model, which are necessary, but that they might actually be someone who has an active naloxone prescription that you know, they just didn't need a new one, which raises a question of what should be the best guidance. Should it be a part of every single clinical encounter with opioids where they're given a naloxone prescription in the event that they need it, if they use it or something expires, and that would be actually a better sort of clinical protocol as opposed to just high-risk people.
Yeah, those are good points, Ross, and I can see that Mark mentioned that there's a concern of misclassification bias. Let me just add a little bit of context about this. So, you know, ideally, you know, we would like to have a prospective clinical, you know, randomized controlled trial to estimate effects. That's what an ideal study would be. Unfortunately, those are expensive, sometimes are not doable because of ethical reasons. Maybe this one here, one of the context, this example. What we are doing here, we are using a resource, a database that could give us some information, but not the perfect information to study this problem. And this is what happens with electronic medical records. They are massive, they have a lot of information. You can't be perfect in designing the study because a lot of variables are not available. A lot of history is not available. Like, for example, if we didn't have access to the provider's notes. If we did, we could actually try what Ross was trying to mention. We could actually dig that out from the notes, right? So we are aware of those limitations. But again, there is some information we could get from this massive database that otherwise there is no way one could study such problem given the prevalence of opioid overdose within those pain types and with naloxone prescriptions. So the size of the studies is too small that you need a massive data to come up with any meaningful results. And this is what we did in here, but we for sure aware of all of these aspects of dealing with electronic medical records. Those are all legit concerns.
Yeah, and we do recognize that this is not going to capture all naloxone. We already, said about the harm reduction program and stuff. And I don't think we would advocate for every single person to get a naloxone prescription, especially given right now there's a naloxone shortage. But what we are finding is that prescribers are finding the people who are at most at need, who end up being the most at risk of overdose, and that's a good sign. So we're definitely not saying everyone should get naloxone, especially given the supply issues right now.
And I could add one more thing. Now thinking about this, what exactly Ross was mentioning, like they had history, but we couldn't capture it. Actually, that will help us if we did commit that misclassification. What will that do? Will lead us to actually a more conservative effect, which means in reality, if we were more accurate with less misclassification bias, the true effect would be actually even higher. So there is no loss of generality in here, because this kind of possible misclassification would have given higher effect, higher risk. And being conservative is legit, but being too liberal in estimation and inflating the effects, that's not legit. So I think we are being in a safe ground, at least with that perspective. And that specific issue that Ross mentioned, if they had, but in that specific encounter diagnosis, they never reported it.
And Dr. Kurthas, you have a comment there. I don't know if it's easier for you to unmute and ask a question. I think you're still muted.
Here, I'm unmuted. Okay. Yeah. So we could infer that clinicians were responding to detectable indicators of concern that don't have anything that you would find in a systematic way in the database used to control for. I mean, you controlled for dose and diagnoses. And if one wanted to draw causal conclusions, which we won't, we would have said, oh gosh, giving naloxone causes overdose. But I really think this study should make us cautious about all the other studies that are influencing and driving our policies in regard to the prescribing and stopping of opioids. The original cautionaries that have led us to view prescribed dose as bad are heavily derived from VA data, like those of Dr. Bonnert, where African-American race and very old age were the strongest protective factors against overdose. That probably hints that there was something else going on in the data beyond the prescribed dose, some complicated, unmeasured things, because we don't really believe that the race or being old protects against overdose. So there's something complicated despite excellent controls. The cautionary paper I helped write with Dr. Oliva was about opioid stoppage, and we didn't conclude firmly a causal conclusion, but it did play a role in saying, stoppage may be dangerous. But if your paper is, if this wonderful, well-done analysis is still hinting at exactly the opposite of what we believe to be true, should we be worried about all the other papers that are driving our policies right now?
Well, Erin, you want to answer this? I could maybe add afterwards some more context to this.
I guess I'm not sure what you mean by it says the opposite of what we know to be true. That
I personally will not walk away. I've just seen a paper which, if very well done, in which the strongest association found is that naloxone is associated with an increased risk of overdose. I guarantee to you that I will not allow that to influence my causal thinking. But there are parallel papers in the opioid space which we have allowed to influence our causal thinking and our policies, which use almost as good or maybe occasionally slightly better measures and techniques and controls. And we have gone ahead and said, no, we're going to treat those as causal for the purpose of altering care. So I'm worried about selectively declining to endorse causal explanations And I'm saying, gosh, if we agree there's something else going on here, isn't there something else going on in all the other papers that are now driving guidelines, documents, declarations, policies? I just heard from a VA which is asking all its providers to reduce doses down to 20 milligrams or lower on all long-term opioid recipients. They're doing it based on observational data of the quality, maybe close to the quality of what you're showing. They're assuming it's causal, but maybe we shouldn't be doing that.
No, we shouldn't.
Yeah. I hear what you're saying. I think we were really careful in framing the paper because of exactly what you're describing, and neither of us want to see a decrease in naloxone prescribing. We agree with everything that you've said in this comment. And I think, the editors at Addiction were also very careful with us to make sure that we address risk compensation just in the discussion to make sure that that was not the takeaway and that it's nowhere mentioned in the abstract, because we know so many people read the abstract and we're really clear with the messaging and implications there, hoping that this is not how people read it. Yes, if they were just to read the results section and that's what they wanted to get out of it, there's probably nothing we could do there. But if they do read the full abstract, the conclusion does really specifically state, this says prescribers are doing what they should be doing and targeting those who are at risk. So we are really trying to be careful. I am very worried about exactly what you're describing. How do we counteract that? I don't know. Ferris, do you want to add anything?
No, I just want to mention what we said in the paper, that we looked at this in different perspective, and we say that we believe what this says overall, that those who are at need for naloxone are receiving the naloxone. This is how we are looking at this. But of course, there is a lot of people, even the statistics, right, will tell them don't think in a causal way. People will, I agree with you, they will think about it, even in the unconsciously they will do it. And that's the problem with those kind of studies, what you glean from them, what conclusion, what implication you get from them. Yeah, so we were a little bit careful. This paper took a year and a half under review. And I would admit here for the first time to, like me and Erin, we know what's going on. We received at one point, I think, 28 pages of comments because this electronic medical records, and there's a lot of issues involved. And until we reach to this agreeable exposure versus non-exposure, and Mark, if I want to go dig back, maybe this issue of misclassification bias of adjusting for those with history of naloxone, new or not, I guarantee you maybe it came up, maybe we did the analysis for it and we backed off because of the reviewers and stuff like this. We did a lot of analysis that we backed off, just given the recommendation of the editor and the reviewers. But we agree with all of these comments and the concerns and all of this. We like you guys, we think about them. We have the same, we share the same thoughts.
We have just a few more minutes. I think one other thing that I thought was interesting looking at the data is that in looking at the quasi-Poisson model, where you had the number of overdoses, that while back pain overall had a lower percentage than chronic pain syndrome, it was like double the number of like 6 or more overdoses. So while it might lead you to believe like, oh, back pain doesn't have as high incidence of overdoses, that there are maybe individuals that have chronic back pain that may have higher number of overdoses or maybe a greater risk for that. I thought that was really striking, that it's a lower prevalence overall, but there was something like 32 6 or more overdoses, which is, at least I would assume those are unique people, so you know that the overdose wasn't fatal for the 5 times before. I know we can't tell before, but the naloxone was doing a job of keeping someone alive and hopefully providing an opportunity to engage in treatment. So.
Yeah, I think that's an interesting point, and I think there's a lot of space there to explore things about this. While lower prevalent, but you have the higher number of like 6 overdoses and more this is pretty interesting. Yeah, looking at the frequency of opioid overdoses, distribution by type of pain and other health conditions, that would be actually something important to look at if we really want to understand these dynamics between naloxone and opioid overdose and the risk compensation, or just those who at high risk and they needed the naloxone, they are receiving. Like, so we are prescribing naloxone to the right people, and that's the whole point. What we made in our paper, that providers are prescribing naloxone to the right people.
We are at the top of the hour. Thank you very much for this presentation, this wonderfully nuanced discussion, which I really appreciate. I look forward to seeing everyone. June 1st is the next PAM Research Working Group, and then we break for the summer. So thank you very much, Dr. Qeadan and Dr. Madden. I really appreciate the presentation discussion.
Thanks for inviting us.
Take care,
Thank
everyone.
you.